We are live now, doctor.
Okay, good evening to all of you. On behalf of Ocular Trauma Society of India, I welcome you all to this webinar. That is, if I see this again, this was basically with the theme that we have an expert panel here who will present their lifetime cases, and we will get expert tips from the panelists here. So we are very delighted to bring together a whole array of illustrious experts in the field of trauma. And I look forward to a very useful interactive learning experience today evening. I now invite the President of Ocular Trauma Society of India, Dr. Purinder Bhasin, to say a few words.
Thank you, Dr. Preeti. Very good evening, everyone here, and those who are listening, and those who are panelists and speakers. On behalf of Ocular Trauma Society of India, it's my great pleasure to welcome all our distinguished faculty, moderators, panelists, and delegate to another edition of our OTSI signature webinar series, which we are going ahead. And it is really wonderful that Dr. Preeti has compiled it so nicely, and our speakers are so elite, and it suits to the theme, because we know trauma is something which is always different, and we learn from each case, and it is not clear cut like a single kind of a thing principle which we can follow for all the cases. So today's theme is very pertinent. If I see this again tomorrow, cases that changed my practice, and everyone has some or other experience, and all these learned and experienced faculty and speakers, they are beautiful and experienced in managing trauma in their subspecialty. And this is not just another webinar, it is an opportunity to learn directly from experience, avoid common pitfalls, refine our decision making, and take home practical tips that can improve care and for the tomorrow. And without much ado, I will request to begin with, and what we have promised to enrich and memorable session is in front of you. Thank you and welcome to OTSI.
Thank you, sir. Thank you for those words. And I now call upon our two very young doctors from the YOSI group, Dr. Prithvi and Dr. Preetham, to take over as moderators.
Thank you, Dr. Preeti. Good evening, everybody. I'm Dr. Preetham from Andhra Pradesh on behalf of Ocular Trauma Society of India. It's a pleasure to have all of you today with us. Rather than the textbook reviews, we have real life crisis situation where the experts will be presenting us. Without further delay, let's hop on to our first presentation. I'll be sharing a small PowerPoint to introduce the speakers. I hope my screen is visible.
Yeah.
So, first speaker for today is Dr. Rishi Swaroop from Hyderabad. He is the medical director and chief surgeon from Swaroop Eye Center. He has multiple affiliations to his name, the latest of which is member scientific committee. He has many awards. I have seen some of them personally. And the latest award, which is not mentioned among these, is in the ASCRS, where he described the basic surgical technique for small incision cataract surgery, made all of us proud. Over to you, Dr. Rishi Swaroop.
Thank you, Preetham. Thank you for the kind introduction. And I don't have a very fancy case, but I think it's something which all of us should see because it can make a lot of difference to our patients. So I thought it'd be good to share. I'll just go ahead and share my screen. Is my screen visible?
Yeah.
Yes.
Yeah, so I've called this From Shattered Spectacles to Structured Vision, a Corneal Comeback. I don't know why my slide is not changing. Okay, So this was a 53-year-old male patient of mine. He was a very active kind of guy who used to play a lot of sports. And while playing badminton on 28th of August last year, which was 12 days before he presented to me. Sorry, he came to me on 28th of August, and he had this injury on 16th of August. And basically, while playing badminton, he was wearing glass spectacles for some odd reason and playing badminton with those, and his badminton racket hit his spectacles, and the glass shattered into multiple pieces, and of course, it injured his cornea. So he had gone to his local nearby doctor, and a primary. In fact, he was a cornea specialist, so I know well. And a corneal tear repair was done primarily locally, and the patient was following up with him, but then somebody had told him about me, so he came to me for a second opinion. So when I saw him 12 days later, his vision in the injured eye was just counting fingers 3 meters and was not improving. And on the examination, of course, there was an unsutured corneal bevel tear in the center in the visual axis. Superiorly, there was a sutured full thickness laceration, which was reasonably well sutured, but there was a central tear, a bevel tear, which is not well sutured. I'll show you that. And there were 2 small lateral lamellar tears as well, which were unsutured. Luckily, the lens, etc., was quite okay, and the rest of the fundus, etc., was normal. So this is how the eye looked. As you can see, there is a superior wound, triangular flap kind of wound, which has been sutured reasonably okay. And there's a central bevel tear, and it's actually a full thickness laceration, which was not sutured well. And in fact, there was an override of the flap, and it was looking quite irregular on the slit lamp. And you can see these 2 small linear cuts, straight cuts on the sides. I don't know if you can see my cursor. And these were also there, but these were reasonably well opposed, and they were not clear as well. The lens was clear. Okay, so I did an OCT, and you can see here now, this was, especially this OCT, you can see the central unsutured tear. This one was full thickness, and it was not well opposed. It was like a overriding cornea. And the one which is sutured also was not perfectly opposed, but reasonably okay with sutures. So that wasn't so bad. This is what the corneal topography looks like. You can see that there's a steepening here, there's a lot of flattening here, and this area is so irregular that the topographer couldn't come up with a color map. So this patient, if you were to leave him as it is, it would heal obviously, but he would heal very irregularly, and he would have very poor quality of vision, especially with the central tear, which is right in the middle of the visual axis. So I obviously didn't want to leave him like that. Being a cornea specialist, you can't leave it that way. So I decided that we needed to do something else for this irregular tear and avoid irregular astigmatism for risks. So we took up the patient, explored the wound, looked for any foreign body, etc. And then basically tried to oppose the suture a little better, especially there's some echo coming from somebody. I think somebody has 2 devices.
Yeah, somewhat depends.
Maybe you can all switch off your mics. Yeah, okay, it's fine now. So the central suture, I just put one central tear. I just put one suture, and I tried to put it in such a way that the visual axis was not covered by the knot. And I also sutured one of the temporal wounds which not cut, and superiorly one of the sutures I changed, which is not good. So this is how it looked after that. You can see this is the one suture which I had changed, and the other sutures were the original. This was the one which had a little bit of override. And this is the central suture, and try to put the knot away from the visual axis. As you can see, this was another bevel tear which I had sutured. Okay, so you can see now in the OCT, the central sutures wound is pretty well opposed. The superior one is still not perfect, but I didn't want to meddle with it too much. So 2 weeks later, the patient started developing loosening of the superior sutures, which were sutured elsewhere. So we took them out as they were getting loose. And at 45 days post-op, the patient was left with 4 sutures, as you can see, and 1 lateral suture and 1 central suture. And the vision at this point had reached 618, and the patient was pretty happy with the recovery of his vision. sorry, yeah. 2 months post-op, the central suture was also removed, and the vision was still 618 parts, 618, and not much improvement in the vision at this stage. And this is what the topography looks like, you can see that this area there's a lot of steepening and there's adjoining area of flattening. So there's obviously irregular astigmatism happening there, even though the Ks are not very high on the same case. The 3 months post-op, there's still 5 sutures and um, 4 in the superior wound and 1 in the lateral wound. That's what the topography looks like, getting a little more regular, but still a significant amount of irregularity. By 7 months, the patient was very unhappy with the quality of vision. He was complaining a lot of glare and was unable to drive. The vision was 6/24, improving with 2-cylinder to 6/9 parts, but the quality of vision was quite poor. And by this time, all the sutures were out. There was just one deep broken suture there. Other than that, all the sutures were removed. But in spite of that, the patient was not happy with the vision, and this is the corneal shape at this point. If you can see, there's still a lot of irregular astigmatism on one side. It's steep, one side is flat. And so at this point, we decided that a patient was a very active person, needed to drive. He said, "Doc, can you do something?" And he'd been off sutures for about a couple of months. I decided that we can go ahead and regularize his cornea. So we did a topography guided transepithelial PRK on 11th of April this year. And immediately, within a few weeks of that, you can see there's a significant improvement in the corneal topography, and the cornea is quite uniform, about 40 dioptrics. See before and after how the shape of the cornea has changed, and we were able to actually give this patient pretty good vision, and he's extremely happy. And he's so happy that now he's taking me on a trek with him. He's a very active hiker. So he said, "Doc, we've become friends, and now we're actually going for a hike together." So that's about it.
Excellent, excellent case, Rishi. Very basic. Dr. Sujata Mohan, would you be able to discuss that case?
Yeah, sure. So there are a few points that we have to learn from this case. Very interesting case, Rishi. It's not a simple case. It's quite a complicated case, I would say, and you have brought about very good results. So there are a few points. One is that when there is a central tear as well as a peripheral tear, I think should first give importance to the central tear because that's where the visual axis is, and that should have been given importance, because once you suture the superior tear, there's always likely to be some gaping and override. So we must, I think the first surgeon should have sutured the central tear instead of leaving it without suturing. And then, of course, suture the rest of the cornea. One way of knowing whether you're opposing very well is I would like to put some air inside the anterior chamber so that we know whether the suture is tight. I mean, tight or loose or perfect. So that gives us an idea about the stretching of the cornea. It may be very difficult when an edematous cornea, as we see in traumatic cases, but it's a little bit of a help. That is one thing that we learned from this case. So take care of the central one, which is closer to the pupillary axis, because ultimately, whatever we are looking for is good visual recovery. The second important...
Yeah. I'll just make a point there. I think the central tear, the problem is it's like a catch-22. You don't want to touch it because you don't want to kind of scar the central cornea.
I can understand it if it's like a beveled incision, but it's through and through.
What was going through his mind.
Yeah, but it is a through and through incision. It's a tear, through and through tear. You can't get away with it. If it is like a beveled or a slash or a laceration, probably you could have got away with it. And in which case you could have put a bandage contact lens and it should have settled down better. But it's you can see the ASOST showing a full thickness tear. So I think suturing, just one single suture which you put really changed the whole game. The other important thing is in situations like this, don't give up on the patient. What Rishi has done is given a beautiful an outcome by using a topo-guided PRK. And most of us now have an access to this. And over the years, we have seen it gives very good results. But yours is really unbelievable, Is it true?
Beautiful results, yeah.
It's really good. So hats off to Rishi. It's a wonderful case. And third point I have to learn is all these important people, VIPs, become very friendly with them, so they'll take you on a free trip.
Ma'am, your husband has a lot of VIP friends, as we know from his real videos.
I don't have. Anyway.
And one more thing, ma'am, the role of OCT, no? That was
OCT,
very
Yes, OCT,
interesting.
yeah.
Could you just
topography and
highlight that,
OCT.
ma'am? Yeah.
Absolutely. See, pre
That
and
is
post.
so
Beautifully
role of
documented.
Is very important.
Absolutely.
documentation, apart from documentation, to understand the case.
Yeah.
I mean, to know what is underlying the thing, why the vision is counting finger 3 meters. So, had it been a simple tear, it would have not, the vision would have not been so bad. So, in the center, any scar would have been. So, this is very important, Dr. Prithvi, you have rightly said.
Multiple tears, corneal tears is always a challenge because you have one superior, one on the side, and then one in the center. It's always a challenge. I think whatever the first surgeon did was best at that point of time. And probably he came to Rishi after the corneal edema and all that had subsided, and it was much easier to view what are the problems associated with this, and he could rectify it. In severe corneal edema, sometimes it may be very difficult to do it.
The
One
role
point
of
I would like
air
to
in
make
the
is,
anterior
you know,
chamber.
it would be very easy to stop at 6x9 part saying that we've got a good vision, but it's always a good idea
Yeah.
to look at the topography. It can really affect the quality of vision, even though in terms of numerical value, you're almost at 6.9.
Correct.
But quality of the vision can be quite bad, and topography is a very useful tool to use in
Right.
this
Any
situation.
tips, Dr. Rishi, for doing topo-guided treatment? Like
I think
what should be
kind of
the
irregular
extent?
corneas, it's always a good idea to do a transepithelial treatment, sir. So whenever we're doing topo-guided treatment, because the epithelium fills up a lot of these, irregularities in the stroma, especially in scarred corneas, there will be areas which are thick, thin. So don't remove the epithelium. Always do a transepithelial as far as possible.
Okay. So what thickness of epithelium you consider? 60 micron or?
So by default, I use Schwind, which removes 55 microns in the center and 65 microns in the periphery and 55 in the center. But you could also just do a flat, 55 microns like many of the other machines do.
So you do a trans PRK with PTK first and PRK, or one single
There's a one single step transfer.
One single, I think.
step, yeah.
I think the discussion will
Now,
keep going
yeah.
on because it's a very interesting topic. Thank you, Dr. Rishi, for bringing us the insights. Over to you, Prithvi, moving on.
So,
Yeah,
next
yeah,
speaker
can
is
I have one? I just want to request Preeti,
Yes, sir.
if after Murli, if I can go, if Niven can present,
Vivian
because
can go.
I'm checking in now by
Okay.
about 7:45. So, yeah,
We'll
if
do
we
that.
can go as the third case.
Sure, sir. Sure.
No problem. Thanks a lot. Sorry for the trouble.
No problem.
our next speaker is Dr. Murli Adiga. He's the director of Swami Eye Clinic and Chennai Glaucoma Foundation. Also, he practices at Chennai with a special interest in glaucoma, lasers, mix, and phaco with premium IOLs. He has held a lot of top positions. He has around 48 publications in his name and 16 book chapters. Sir, I would like to welcome you next for the speak. Thank you.
Thank you, Dr. Prithvi, and my sincere thanks to OTSI, especially Dr. Preeti Uday, for this kind invitation. And it's a pleasure to be here today with among these really nice lineup of trauma cases and presentations. Am I okay with the slides?
Yes, Dr. Murli.
Yeah. So I'm going to speak primarily about some tips, tricks, and some of these problems which we face with regards to trauma and glaucoma, with regards to angle recession glaucoma. My presentation is going to be very brief with maybe a video clip at the end. And yeah, this is a tale from two cities. The background is that this was a 56-year-old male patient who presented to an ophthalmologist in Chennai about 6-7 months ago with a unilateral blurred vision glare, was diagnosed to have cataract and was advised a routine cataract surgery. The other eye was completely normal. So he underwent uneventful left eye phaco-IOL surgery by an experienced cataract surgeon who actually sort of inquired with the patient intraoperatively whether there was any history of previous eye trauma. The patient then recollected and told the patient intraoperatively that yes, he had some trauma in childhood when he was playing some sport. The surgery was apparently uneventful. There was no problem with the surgery. But for some reason, the patient was puzzled as to why the questions were asked intraoperatively as the surgery was going on. The other eye was apparently normal in all respects, and he was 6/6 and 6 vision. So post-operatively, the patient continued to have mild blurred vision, and intraocular pressure remained on the higher side. I think IOP was measured regularly and found to have 28 to 30 millimeters of mercury. Started on one combination medication, remained uncontrolled. A prostaglandin was then added. Then he went back to his hometown, couldn't stay back in Chennai, consulted another glaucoma specialist in his hometown, and therefore there he was diagnosed to have an angle recession glaucoma. About that's what he patient recollects, saying that about half the angle there was an angle recession kind of a glaucoma. He was advised another procedure to control the intraocular pressure as the IOP was not getting control, and the surgery, according to the discharge summary, was a suture GAT that was performed. Almost the next day post-op from a 6/9, 6/12 vision, the patient's intraocular pressure spiked to 40 and 50 and remained high with very blurred vision, corneal edema, and a hyphema, which is persisting for several weeks. And then finally, patient decided to move on to Chennai, and then he was referred to us for an opinion. So this is the Chennai story again. So right eye was normal in all respects, and the left eye, when he came to me, was very high intraocular pressure on nearly maximum medication with a triple combination, prostaglandin as well as oral acetazolamide. A hazy cornea with pigment on the endothelium. Everything was quite blurred, a very hazy view of the angle. I could make out about nearly 3 quadrant angle recession, complete angle recession with the evidence of the GAT goniotomy from the nasal. And I could make out that GAT was probably attempted in about 180 degrees or more. There was intense trabecular pigmentation all around. View was not very clear to take good pictures. The PCIOL seemed to be in the bag. There was no CTR, there was no lens subluxation or pseudophacodonosis. So I could manage to get some disc pictures of the right eye, which is looking completely normal. And the left eye disc, as you can see, has clearly shown evidence of the raised intraocular pressure, and the disc damage was evident. Because the cornea was so easy, we just had a doubt regarding the endothelium of the patient. So just as a precaution, I took the endothelial measurements counts for the right eye as well as the left eye. To my horror and surprise, I see the endothelial count was very, very low in the left eye. Cornea was reasonably clear by the time I had started to see. So the intraocular pressure still remained high. The pressure was 36, 38, even despite whatever we have Diamox and Trisopt as well as the prostaglandin. So after prior voluntary and informed consent, the options of various types of procedures to control the intraocular pressure was discussed with the patient. Possible complications, alternatives, trab, tube, and diode, all of this was discussed with the patient. And he took a week or two to decide, went back home, had maybe probably another opinion, and he came back to us again. And also discussed the need for a future corneal surgery because endothelial reserves seem to be so low. So we suggested a mitomycin trab with a mitomycin of about 0.4 mg per ml for about a minute with a releasable single apex releasable switcher, which I usually always do for most of my trabs. A very guarded prognosis was offered, and preoperatively we tried to control the intraocular pressure with the mannitol intravenous about an hour pre-op. The surgery was reasonably uneventful. I just show you a very short video clip of the trap. This was after mannitol, after all the medication, and after the eye was reasonably quiet with some steroids. Mitomycin is being applied now. I usually take a triangle flap with a 300 micron depth, 300 micron blade, usual triangle scleral dissection, and quite uneventful surgery, and one apex releasable suture. Taking care not to enter the eye much, taking care to keep the chamber formed. And also the mitomycin was applied very meticulously to avoid any kind of mitomycin getting into the eye, kind to remain posterior and so on. Kept the chamber formed at all times so that didn't allow the AC to shallow. A quick releasable single, this is my usual technique of a trap of a single apex releasable suture. So surgery went on well. And this was the post-operative appearance of the patient, maybe about a few weeks post-op, but nearly about a month now. And patient continues to have a good, well-formed, diffuse, relatively avascular bleb. Intraocular pressure is about 13, 12 now. about 1.5 months after the surgery. And the cornea remains clear despite the low endothelial count. The endothelial count was repeated, by the way, just to make sure that there was no error in the measurement or estimation of the corneal count. So what are the lessons to be learned and maybe discussion points for Dr. Rani also to discuss here? The unilateral cataract, and to look for the telltale signs of old trauma and not being casual about it and posting up for surgery. And that was really a worry because patient was taken aback when he was questioned about trauma during the cataract surgery. An angle recession glaucoma, was it missed at that time? Did it have a delayed presentation? And then there showed up after the cataract surgery, and therefore the emphasis on angle recession, old history of trauma, and the need for long-term follow-up, especially with childhood trauma and so on. And the rationale for managing uncontrolled, medically uncontrolled angle recession glaucoma is a MIGS appropriate, and is the MIGS which was used in this, employed in this patient, is it an appropriate method? And how do we deal with the problems with the MIGS and the MIGS-related hyphemas and so on? And of course, the worry about the last surgeon who operated, that's myself, regarding the use of mitomycin trap and the low endothelial cell reserve. What the future problems, what problems the future holds for me and for the patient in the near future. Thank you for your attention.
Thank you, sir. I would like to call Dr. Rooney George for sir to give your comments on this.
Thank you, Prithvi, and thank you, OTSI. This is a very interesting case that Dr. Murli has presented. And one of the key things here is, especially when you have an asymmetric cataract, is to try and find out whether anything has contributed to it. And in this patient, definitely a good intraocular pressure and gonioscopy would be excellent. But what you might have actually picked up would have been with a good pupillary evaluation itself. Since the nerves are looking fairly asymmetric, you may have just picked up that there's something going on at that stage in time. The cataract was well done. And after that, the secondary glaucoma, difficult to treat. And doing a MIGS in this situation is actually the wrong way to go. Because in angle recession, what you're having is trauma to the angle. And in MIGS, you're targeting the same area. So when you have an unhealthy angle, anything that you do there is not really going to work. And in angle recession, where your iris has disinserted and gone posteriorly, even identifying structures is challenging. And what you're doing with, especially a 360-degree GAT or nearly 270-degree GAT, is you're also targeting the normal angle in that patient. The degree of damage that you see on recession may not explain the true extent of angle compromise, because in these patients, you typically can have a little bit of trabeculitis soon after the injury. You can have scarring there. And whatever little angle is functional, if you get rid of it, then there's very, very little chance that that angle is ever going to recover. Because angle recession glaucomas can show up even 30, 40 years post-trauma if you are not careful. So I mean, I would agree completely with Murli that if this patient required a surgical intervention, we should have maybe gone with a trabeculectomy. We wouldn't have had this terrible picture. And a lot of the endothelial cell loss is possibly related to that blood sitting in the eye for a long time after surgery. Whenever you use mitomycin, you are always a little worried about the endothelium, because if the mito goes into the eye, you can actually wipe out the endothelium. But Murli has very carefully used the mitomycin before he opened anything, before he even made a side port. And that is the safest thing to do. And he followed his usual technique, with which he is very comfortable of one releasable. The only thing that I might have done a little differently is I might have put in a couple of more sutures to avoid any shallow AC post-op. But Murli followed what he always does, and that works for him, which is perfectly all right. But if you're not sure about it, it's always better to put in multiple sutures and then release them as required. And always ensure that the antechamber is well formed on table without any significant leak, so that you can titrate it post-op. In the long term, he's 56 years old. Whether that endothelium is going to hold on for a lifetime, I don't think so. And anyway, the trap is done well, and whatever IOP-related pressure damage endothelial damage we expect going forward is probably arrested. I think all in all, it was a difficult situation, but managed very well. And if the patient is a little lucky, he'll probably manage without a corneal procedure in the future.
Thank you, sir.
Thank you for the lovely tips.
So next we have Dr. M. Nivian. He is a vitreoretinal surgeon at MNI Hospital, trained at Arvind Eye Hospital, Madurai. He is the first surgeon to have performed a live 3D cataract surgery in South India. He's also the youngest surgeon to perform live surgery at major conferences like TNOA, APOS, IARSI, and he has a lot of awards to his name. I would like to welcome him for the next talk.
Thank you, Prithvi. I'm just going to share my video. I think you have to stop sharing. Prithvi? Preetham?
Yeah.
Yeah, thank you. Can you see the screen?
Yes,
Yeah,
yes,
yeah.
yes, Divyan, we can see
Yeah,
that.
yeah.
Yeah, go
So
on.
respected my dear friends. So I'm going to praise an interesting case of an intraocular foreign body and a new vitreocapsular approach of bringing it out. So we all know that trauma is one of the leading cause of visual blindness. So I don't have the pre-op slides with me. So this was a case of a 52-year-old male patient that had a trauma while working in Mahabalipuram. So he was a sculptor by profession. So he had a stone injury and then he had done a primary wound repair in a tertiary eye care center. That he had further deterioration of vision. So as usual, he had come for a second opinion. So that time we saw there was a dense vitreous hemorrhage, ocular foreign body. So basic plan of action was to do a pars plana vitrectomy to clear the vitreous hemorrhage and to locate the foreign body and to remove the foreign body. So we are going ahead with a 3-port 23 gauge pars plana vitrectomy. The only trick, this thing is we should make sure that the infusion cannula, as you can see, is longer and you don't want it going any subchoroidal or subretinal because we are not able to see the retina. As you can see, it's got a dense traumatic vitreous hemorrhage. And so we usually prefer to do a multi and always periphery because in these cases, even though we have the B scan to guide us, sometimes it is very difficult to know whether the retina is also attached along with the vitreous hemorrhage. But once in the periphery, you can see once you clear the vitreous hemorrhage, you're able to see the vessels. So that gives you a little bit more confidence that yes, the retina is attached. So you have one less problem to deal with in these types of cases. So then you can go ahead and complete and do the entire vitrectomy, removing all the vitreous hemorrhage in the periphery. As I could trim it, you could see that the foreign body was impacted at the macular area, but just luckily just averting the fovea. You can see there a large stone foreign body that is there. So the first thing was to make sure to remove it and not have any bleeding because once you have an active again, then you'll have to wait with FGE. So once the foreign body was removed, I think because it was a 2-week duration that the intervention not done, there was no bleeding actually. So now the cap comes. So what are the various options we have? So we usually are trained to do with the scleral route where we have to extend the sclera and remove the entire foreign body outside, or we can perform a lensectomy through the anterior segment. But then we thought, why not have a different approach since not only cataract has become a refractive surgery, even retina surgeons are doing refractive retina surgery and to give good visual outcomes. So we thought, why not do a phacoemulsification, make a posterior capsulorhexis, and then remove the foreign body through the clear corneal incision. By this way, we are able to preserve the lens and also give a good visual. So the idea came, so then we went ahead, and since this is also a 52-year-old male patient, there can be instances of cataract forming post any vitreous surgery in the normal cases. So getting a good capsular access in this particular case was very essential because if anything rupture or anything goes wrong, we still have to have a good anterior capsule to place a 3-piece lens in the sulcus. So just making a normal 2.8 millimeter clear corneal incision, just making sure it is more biplanar in this case in case I need to extend it later on. So not doing a direct clear corneal entry. So once the rexis is completed, as you can see here, it's actually there is no cataract actually. So it's just a aspiration of the lens, a good hydro and a hydro delineation popping out. And with low bottle height, because in these cases of post vitrectomized eyes, sometimes once you go in, the entire thing goes back and you can drop the entire nucleus. So just in the anterior chamber, just aspiration. But here again, you see, I didn't use the side port. So basically, I didn't want to rupture in this case. So the cortex was aspirated. So now just slightly extending the wound. So now using the vitrectomy cutter, just making a posterior capsular excis. I think inspired by Dr. Mohan Rajan's puncture excis. So it is not the anterior capsule that we are puncturing. We're actually making a small opening, a smaller anterior capsule, so that we can still plan for the IOL in the bag. So once that is done, so going in with the intraocular forceps, holding it at the least diameter, just lucky with the shape of the foreign body. You can see that just grabbing the least diameter and then gently passing it through the posterior capsular axis and the anterior capsule and then leaving it onto the iris. Here the trick is to use the fluidics. So here at this time you should make sure that you and then put in some viscoelastic, because there has been, if the infusion is still running, since you have a small defect, the tendency according to physics is it again can go back into the vitreous cavity. That is how we lose most of the times when we have the lens with a large rupture. When you go inside, it goes back inside. So once that is done, again just maneuvering the foreign body, grasping it, and from 2.8 maybe we must have extended to a 3 or a 3.2 millimeter corneal incision. So you can get that entire large foreign body through your clear corneal incision, as you can see here, the large stone foreign body. So once this is done, yes, the whole concept for why this was done is we'll have to give some amount of refractive benefit to the patient also. So we had planned to go ahead with the foldable lens in the bag, and the lens that we choose in this particular case was the in-focus lens for two reasons. So basically the in-focus lens has a small plus add power in the center. So basically it gives you a slight bit of magnification because the trauma was very close to the macula. So that is the reason why we plan to go ahead with the in-focus lens. As you can see here, gently just putting the leading haptic into the bag and then just nudging the trailing haptic, not like usually dialing it. So just nudging it. Here again, making sure, because we have a large posterior capsular axis, just go back for any trauma case, make sure you go recheck all the periphery of the retina, search for other breaks that you can find. Also see if there are any other foreign bodies. Sometimes, most of the time, foreign body, you can find multiple foreign bodies when you go inside. So once a careful examination is done, no further laser was done in this particular case, because some of the studies says because of the impacted foreign body that causes some healing. So unless there is an obvious RD or a tear in that area, you don't have to go ahead and laser it. So fluid gas exchange was done. The only lucky thing was there was no bleeding here. So once that was done, this is how the case ended. You can see the lens well centered. And post-operatively, he did well. Actually, now almost we have like a 5-year follow-up. Yes, from the initial 618 or whatever he gained, he did lose some vision later on. That was because the scar slightly enlarged into the central zone also, but the patient is still happy. So once again, thank you, Preeti, and thanks, OTSI, for this wonderful opportunity.
What
Thank
an
you.
out of the box thinking, huh? Superb. Dr. Mohan Rajan, please quickly, if you could give us some
Yes.
tips on this case.
First of all, let me compliment Purendra Basan and OTSI for the wonderful webinar, because they've been doing this on OTSI on a regular basis. Very good. And Preeti, really credit goes to you for coordinating the whole thing.
Okay.
Nivian, you always have good lateral thinking. Nivian does not have any straight thinking at all. It's only lateral thinking he does. And he is another example of this lateral thinking what he has got. The only thing is, you have done a good vitrectomy and you have identified the foreign body. It's impacted very close to the fovea. Uh, my this thing is because it's a very ragged foreign body. Okay, and there's a lot of how-
I think,
Your network, I think, is
yeah, or is it mine?
because yeah.
Sir, we got
Which
you back. Yeah.
which route the foreign body went inside?
To the
Because
sclera, sir. There was a scleral wound, and then that had been already
where was the
identified.
scleral wound?
Infrotemporally, just behind where
Already
I took.
primary
Yeah,
repair was done elsewhere.
yeah, elsewhere. There, almost
Primary
3 weeks duration.
primary repair done well, sir. So you've done a fairly good vitrectomy, and I would also not bring such big foreign bodies by enlarging the sclerotomy. So I think gone are the days wherein So I think you have done it very nicely. Only thing is the posterior capsular axis with the vitrector is not as controlled as a manual capsular axis. Please understand that. Because when the vitrector, no, you don't have the control over the edges of the capsular axis. Whereas if we do a manual capsular axis, like through the anterior route, then you can actually get a beautiful, nice, round capsular axis, which is very strong in the periphery. Okay, just like the anterior capsular axis. The posterior with the cutter, the control is not there as much. Sometimes when you try to bring this ragged foreign body through the posterior capsular, it can cut the posterior capsular axis, and the entire battle is lost. Because once the posterior capsular, the tear is there, very difficult to put a lens in the back. But anyway, you got away with it. And why an in-focus lens? The EDOF lens, because macula was already screwed up a little, and straight away you could have put a monofocal plus lens or whatever it is.
I think, sir, I think you and Arul sir were the initial people who did the study on the in-focus. So basically in macular pathology is also like one of the indications that is expanding in EDOF lenses are in glaucoma patients, in retina patients also, you can use them. And they give an additional ad. I think this lens has up to 1.75 an ad. So that is the reason, sir, that I went with this lens.
Yeah.
More like a magnifying concept for the macular. For even
What
ARMD, they came up with
was
those.
the ultimate vision for this patient?
The last follow-up, initially it was like 618 partial, but then later on it dropped to 636 partial, sir.
Because of
That
the
is because
scar,
after the scarring. Yeah, yes, sir.
because scar very close to the fovea.
Just the fovea was escaped, but in the macula, yes, sir.
It's probably away from the thing, then I would have done a laser also. Because very close to the fovea, probably you avoided the laser also. So, but during this thing, I could see some very red glow. Probably was there any vitreous hemorrhage also?
Not
Good.
intraoperatively, sir. That time I had switched off the infusion cannula, sir, because the foreign body was there. So that time you could get that red reflex.
Yeah, yeah. Otherwise, well done case. It's out of the box thinking. I think which is we can do because many people are shown no removing the oil also through the posterior capsular axis. Okay, silicone oil. It's able to hear me?
Yes, sir. Yes, sir.
That's the same way you remove the foreign body. The only thing is the removing the oil, I would not suggest, because unless you examine the posterior segment nicely, you can't just go do an anterior approach and remove the oil through a posterior capsular axis. So you have to do a 3-port pars plana vitrectomy and then probably do the oil removal. So, but a foreign body like this, because already you've done a good vitrectomy, mobilize the foreign body very nicely. So you induce the PVD and made sure there's no traction on the retina and everything is fine. I think you've done a very good job, Niven. Very proud of you.
Thank you, sir.
Thank you. Thank you for
Thank
the
you, Dr. Nivin. Thank you,
Thank you.
Dr.
Thank you,
Rajan,
sir.
for your comments. Next up, we are moving ahead. Dr. Almozi Varman sir will be doing our next talk. He's the chairman of OMI Clinic.
Hi, Arul.
Sir, I would request you to share your screen, sir.
Yeah. Let me quickly find. Can you see my screen?
No, sir, we can't see your screen. You got to share it again.
No, I'm on Zoom. Are you allowing me to share it? Where is the share screen? Default. I don't have a share screen setting coming up here.
Arul, your press button is working well, I suppose.
But I'm not able to share my screen. I have the thing on desktop.
No, you do one thing. You bring that PowerPoint onto your desktop and then share and then hit on.
Close it and then open the PowerPoint and then.
The PowerPoint open.
Sai, anybody can help
Yes,
Okay,
doctor.
close the
from the
PowerPoint.
team?
Okay. I'm going to open it again. Yeah, it's ready. Is that okay now?
We still can't see your
Still not able to see.
You're able to hear me?
Yeah.
Yes.
Yes, we can. But are you signed in on two devices, sir? You'll have to sign out from one
Because
the echo.
okay, I'll shut down one device.
Hmm.
Is it okay now?
And yes, now it's okay. And now you open your PPT on desktop. Is it open, sir?
No.
Yeah, open that on the desktop first.
That's the problem. I think okay, let me shut
Come
down
out
this
of the Zoom.
device.
You have to come out on the
There
Zoom.
was a problem with my okay, done. Can you hear me now?
I can hear you, sir, but your PPT is not seen.
Yeah. PowerPoint.
You come out of the Zoom screen, sir,
I've shut down the device.
and you'll have to come out of the Zoom screen and go to the PowerPoint.
Can you see me now?
We can see you, but not the PowerPoint.
see you, but oh,
I think your PowerPoint is not open. Is it open, sir?
is it open? Yeah.
You're sharing the screen, no, sir? You have to use the screen share.
Screen share. No, 1 second. I'm on the Zoom now.
Z-
Yes. Now on the bottom there is a share, no?
Then there is a can't make out the share screen button anyway here.
It is in the bottom.
Bottom you can see chat and
Bottom you
chat
can
and
see
share.
Okay, fine. I'll come to
Yeah.
that.
So that
You
share
want the chat, is it?
press.
Okay. I don't see any scans. No, on chat also I don't see sky.
No, not on chat. Screen
Not on
share.
chat.
Uh,
Yeah, I don't see
Next
that
to
at
the
all.
chat, no, there is a
Next
react
to the
and then
chat.
there is a share. That share, if you press,
Share if you press.
you do share not only the PPT, but share the whole screen.
Not only
You will get an option of share whole screen and share PPT. You should share
and
whole
share.
screen.
There's a chat screen, there's a react screen, there's a Zoom AI and more. Something is wrong with my settings.
Yeah, probably.
Probably.
Because you might have removed from the
You
toolbar.
might have removed.
Sir,
Oh,
can
I
you
have not.
share your slides,
Okay.
sir, on the WhatsApp group?
1 minute. WhatsApp group.
Yeah, you can just share it on the WhatsApp group.
WhatsApp
And
group,
we
one of
will
us will
take
share
it.
the
WhatsApp group.
slides.
Meanwhile, we could maybe take Dr. Sachin's
We could maybe
presentation.
take the suggestions. You can do that. I'll come back.
Yes, sir. And just share your presentation with me or with somebody else, and
With me
we
or
will
with
present it. We'll put it up.
See, there's an echo from your side.
there's a link.
I think they can use the team viewer and do that.
The team viewer and
Next, we have Dr. Sachin, Director, Head of Vitreoretina
head
Surgeon.
of it.
There's an echo coming, so I think
There's an
Yeah,
someone-
oh, everybody is echoing.
Go on
Something wrong.
mute, sir.
Echoing.
Arun, sir, go on mute.
So next, I would be introducing Dr.
So next I
Sachin
will be
Mahoney.
introducing Dr.
Can we? Am I audible now?
Yeah, you're audible. Go ahead and
So
introduce
we
him.
are we are introducing Dr. Sachin Mahoney. His affiliations are Honorable Secretary of Karnataka Retina Society, Director Retina Surgical Circuit Association. His major areas of interest are retinal vascular disorders, diabetic retinopathy, and retinopathy of prematurity. Over to you, Dr. Sachin.
Thank you so much. Thank you for that kind introduction. I thank Dr. Preeti and Ocular Trauma Society of India for this opportunity. I'll be sharing two interesting small cases. Are my slides visible?
Yes, Sachin, go on.
So they're two short cases. Hopefully, I'll finish in time. Just a minute. I'll just play this. Okay. Continue to share. Fine. So this is the first case. No, slides are not moving. I'll share it again if you don't mind.
Is it on Keynote or PPT?
It's on Keynote.
Oh,
Is
that,
it fine now?
yeah, it's a fine. Move to the next. Yes, it's moving.
So it's some very unusual things which I have noticed during two of my surgeries. This is the first case, 52-year-old gentleman with history of blunt trauma a month back. He was a phakic and hand movements vision. When I saw him, he had some vitreous hemorrhage and large retinal tear with PVR. I could see everything in the vitreous with some vitreous hemorrhage inside. Mostly at this time, I did not do a B scan because I was able to see most of the things. This is a short video of the surgery, wherein I'm starting with three-port pars plana vitrectomy, clearing up the vitreous. And I saw there's a lot of PVR with a lot of vitreous hemorrhage and a RD with, so much of a. So here, there was this lens which had dislocated from the anterior chamber and had gone behind the retina. So which is very unusual, usually goes because of the large tear, it had migrated in the subretinal space. So after managing the PVR, removing all the membranes on the retina, I used a PFCL to secure the macula and um, float up the IOL. And once the IOL, am I audible?
Yes.
Am I audible?
Yes, sir, you are
Yes,
audible.
yes, Sachin, very well. Come on, go on.
So I floated the IOL up and I settled the retina well with PFCL, and I've done the laser now. You can see a 360-degree barrage with the relaxing retinotomy which was done to manage the anterior PVR. The IOL is brought in the anterior chamber and kept on the iris. And after this, a scleral tunnel was created to remove the IOL. So was removed with the bag, and then the scleral tunnel was ruptured, and later on PFCL oil exchange was done. Right now is very well attached. So this is the first case. And the next case also is something like this. It was a different lens though. A 40-year-old male presented with corneal perforation, large limbus to limbus cut, which primary suturing was done elsewhere. Patient had hand movements vision and total hyphema was there. And we did a CT to find out if there was any intraocular foreign body, but CT could not pick up any intraocular foreign body. And post-traumatic NIRDA was there, but for very surprising, the lens was very clear. The crystalline lens which was there, which was very clear, but there was a zonular dialysis in 4 o'clock hours. And patient was wearing a soft contact lens at the time of trauma, and it was not retrieved by during the surgery, and so primary surgeon thought it had fallen away. So a B scan was done, but nothing was picked up on B scan. So this is a surgical video in which you can see the vitreous hemorrhage is cleared to some extent, and once the vitreous hemorrhage is cleared, you can see a shiny thing which is floating in the vitreous cavity. That is a soft contact lens which has gone through those 4 clock hours zonal dialysis without damaging the lens, and it is migrated to the posterior chamber. So now the challenge was to remove this contact lens. I stained it with trypan blue so that the visibility of the lens is better. This was the key trick for removing it. The lens was very fragile, so it was breaking as when I was holding it with the forceps. So decided to do a bimanual dissection of the lens inter and the vitreous cavity, cut it into small pieces, and try to pull them out through the sclerotomy. But it was so fragile that it was coming in small pieces. But the large pieces we could remove from the sclerotomy itself with the forceps, as you can see there. And the smaller pieces were cut off with the cutter using the cutter. So the key here is the best thing was to stain the contact lens so that we don't leave a small piece of contact lens in the vitreous cavity. And as you see, the small pieces are coming very well in the cutter. Then the surgery was completed by doing base excision and visualizing the periphery and other things. Patient was left aphakic at this stage, and later on was taken for an SFIL. So what do we learn by this is, in every trauma, we have to image all these cases. In the first case, as you said, I should have done a B scan to, see that IOL which is sitting behind the retina. That's one thing which I learned. And intraop decisions always vary in trauma cases. They don't relate to what is your decision pre-operatively. So you have to be ready for surprises. And in the second case, as you see, only a simple step of staining the contact lens made my life easier. So timely intervention and meticulous surgery is very, very important in these cases. Thank you so much.
That was brilliant, huh? Straining that contact lens. I'm seeing that for the first time. Very beautiful tip. Thank you so much.
Wonderful.
LG sir
Wonderful
will be
case, very
discussing
well
the
managed.
yeah, very beautiful.
So why this lens was so fragile? Is it so
It
the
was lying
meticulous?
down in the vitreous cavity for long, probably. It was very fragile. I would not have removed it in toto from the sclerotomy. So I had to cut it after staining.
Very, very
LG
beautifully.
Dr.
This is
Nima
worth
Gopal,
presenting.
yeah, lovely presentation.
Yeah, yes, I think the two nice cases which were handled very nicely by Dr. Sachin. Regarding the second case about the soft contact lens, I have just one point to make that very often if you take a forceps, if you can twist it into a scroll like thing, it can be squeezed out through a slightly enlarged sternotomy because it tends to fold very easily compared to something thicker, a soft lens. But I'm sure making it into small bits and removing it is also a perfectly acceptable option. Regarding the when he said the unwanted guests in the vitreous cavity, when there are injuries with any sort of thing which goes inside, they can carry with it lots of things around the eye as well, including the eyelashes, which is a very common finding. And there has been a lot of uh, discussion and controversy about eyelashes can cause very specific reaction in the eye. Most often, the eyelashes are not the cause of the reaction. The reaction is mostly caused by the injury itself. But again, as I said, there is a school of thought which says that eyelashes are organic material. It can incite more reaction than something else like a glass piece or material which may not cause inflammation in the eye. Having said that, we published something about eyelashes nearly about 20, 30 years back, where we have seen eyelashes sitting in the eye. It's another interesting unwanted guest in the eye following an injury. That's all.
Thank you. Okay, we cannot hear you, sir.
I can't hear now.
Yes, sir. Can you hear us?
Can you hear us?
The dislocated IOL behind the retina.
Yeah.
Okay, so that's not very uncommon, but something which I will share with you, which Dr. Bhatwar had an experience of. He was operating and he was removing a glass foreign body within the eye. And removing it, supposed to be from the forceps.
So we can't hear you very well.
You could again space extra process it over the chloride and the eye abandoned. It's again a very difficult problem when it goes into separating space. Beyond the diagnostic species, the upper offense is the consent.
So we cannot hear you very well. Your voice is breaking.
I think it's traveling. There's network issue.
Yeah. Sir, can you hear me?
Yes, I can hear you now.
The last point we couldn't hear very well, sir. You were describing
Dr. Badrinath's
Dr.
case.
Badrinath's case.
No, that is just basically glass piece which went subretinally during surgery.
Okay.
Okay.
Yeah, so it just cut through the retina and went subretinally, and then he couldn't do much about it because the glass piece cut the choroid as well. There's massive bleeding. And so when you're removing a non-magnetic foreign body like glass or even the stone piece which Nivian was showing, you should be cautious in handling it because the minute it slips out of your hand, it not only is heavy, but some of the edges could be so sharp that they can cut through the retina and go subretinally. Then if it goes through subretinal space, it migrates to the posterior pole. And hence, you have to make a large retinotomy to reach that rather than trying to fish it out through a small hole. Then you cause more damage to the retina, to the choroid as well. These are the things I wanted to make, nothing more. Thank you.
Thank you.
That's a very useful tip, sir. Thank you so much. Dr. Purinder Vasil, you were also commenting something, no, sir? Any
No,
comments
it's
on
good. It was both the cases were very interesting, and I really appreciate the presentation and the comments. Thank you.
Moving
Dr.
ahead.
Dr.
I'm ready.
Arul, are you
I think
ready with your?
I was not allowed to share. I didn't have the share button. Now I'm fine.
So please welcome to OTSI.
Okay. Thank you for having me. Let me just share my video here. Right. It's on. You can see that.
Yeah, yes, we can see your
Finally.
presentation.
Finally.
Yeah.
Okay. I'm fine. Okay. This is just an interesting, what I call as trauma Pandora's box. You don't know what will happen or what, long period of time. So this is, 1 minute. You can, throw up seemingly unending surprises. So this is a 9-year story. That's what I take you across. So this starts in 2017, where a 50-year-old male came to me with a shuttlecock injury. So in the right eye, the vision was HM. There was hyphema, significant hyphema. The B scan showed a vitreous hemorrhage, and the retina was all fine. And IOP was 52 millimeters of mercury. So medical management, and then on day, we just very next day, because of the amount of blood and we could not make out what was there occurring into the lens, the anterior chamber, AC lavage was done. We found there was a little bit of phacodonosis. And by day 7, the vitreous hemorrhage was very small, kind of improved, and his vision improved to 6/9. So the next 2 weeks, though the patient was quite happy, we noticed a rapid increase in the lens opacity. There's a phacodonosis, and he was starting to develop a traumatic cataract. So vision rapidly dropped down to 6/36. So starting day 20 after the injury, we did a phaco, a CTR, IOL, and he was fine. His vision was 6/9. And with topical AGM, he needed AGM, and the vision of the IOP remained at 18. So we're all very happy. But week 8, things started to unravel. The IOP started to increase, and of course, we had already done a gonioscopy, which showed a lot of pigmentation and angle recession, which was about only 60 to 70 degrees. But then the IOP started to go to 32, and it was not controllable. And also, the patient was complaining of glare due to the fixed dilated pupil after the injury. So we planned for a trab with pupilloplasty, and the same was done right away on week 8. So, but that's about day 55. So postoperatively, 7 days after the trab, his IOP dropped down to 18, and his best corrected, even uncorrected visual acuity was 6/6. For near, he needed a plus 2.5. And he was followed up. He needed 5 FU injections to combat blood fibrosis, maintained 6/6, well-controlled IOP, normal disc, normal macula, normal retina, and then things again start to unravel. He comes back 11 months after the first trauma with a second shuttlecock injury in the same eye. So now the vision still remained 6/6, but pseudophacodonosis was starting to develop. And we manage him conservatively, all fine. And we're following up for the next 5 years with stable vision, IOP, but the progression of pseudophacodonosis was increasing every few months, but patient refused any intervention because the vision was stable at 6/6, and he refused to do anything about it. But after 5 years, the IOL, the CTR complex, subluxated, with the CTR was intruding into the AC and touching upon the posterior part of the cornea. I said, enough is enough. Please have the whole thing taken out. So they advised IOL explantation. The same was done. First pulled out the CTR, and the lens sank down a little bit into the anterior vitreous. Then we did a small vitrectomy, got the lens out. And put in a iris claw lens. We had to put it in vertically because he had a superiorly placed glaucoma bleb. So this went on fine. So again, 20 days post-op, the best corrected visual acuity improved to 6.9 with a minus 0.5 spherical and a minus 1.75 cylinder. Patient was quite happy. Everything was good, but he needed a couple of anti-VEGF injections for CME, secondary to the iris claw lens probably, and vision and IOP was stable, disc was stable. But year 6, cornea started to decompensate. This probably is the multiple surgeries as well as the CTR that was rubbing on the posterior part of the cornea, then the CCT 0662. So now what are we going to do? So we decided to explant that, take out the iris claw lens, put in a scleral fixated lens. So if you try to do a DSEC and then put an air bubble with a iris claw lens, the whole thing can start spinning and the air can go back, or sometimes the whole thing can spin and twist the iris out of shape. So we explanted iris claw, scleral fixated, and a DSEC. Now this is 2 years after that. He maintains a vision of 6/9 with +1 spherical with a minus 2.5 cylinder, IOP of 17, and the retina is quite stable. But you can see that how much of handling and the iris is really messed up. So this is how his retina looks now. So you can start 2 traumas spread over 5 years, multiple issues over a decade, and multiple interventions, but eventually everything settled down well. And we're keeping fingers crossed that he doesn't come back with something else next. Incidentally, he brought back his friend with a similar shuttlecock injury. We couldn't do much for him because he developed a large macular hole. Thank you.
Wow, I think it is because it was you, you could do all this.
No, I did only the
Amazing.
cataract and the CTR, and then the iris claw lens. But the rest of it is done by the cornea team, which is Adit and his team.
Amazing,
Okay.
amazing.
I think we should not give up. That is the message here. What I feel is, and at the end, the disc is okay, retina is okay. This is amazing after so many surgeries. So we should not give up and right decision at right time. That is very, very important. And the message, what this case, and a long story, but long follow up, and a patient has trust on you. That is the reason why he has not gone anywhere else. This is
exactly what I get at. The hero of the whole thing is the patient who refused to give up, kept staying with us. I don't think he went for a second opinion anywhere. I mean, I appreciate him. He just kept at it.
Yes, sir. Yes, sir. Congratulations for that. You are well managed. So that's a big point. So we should not give up any case at any time.
Yeah.
Always we can think in positive way, especially in trauma. We don't know. And even a very simple case, little bit of iris, the injury during the phaco, normal phaco also creates lots of problem. So trauma means need a lifelong follow-up. That's the take-home message.
Yeah.
Yeah,
I think
Lifelong.
pre-counseling itself, no, when we see
I
a
think,
trauma patient, we tell them
Yeah.
that you will need multiple stages to prepare them initially itself.
Yeah.
yeah,
Or any
wonderful.
case.
This is really example about the no boundaries for trauma. There are no
Yeah.
segments, no anterior, no posterior, no glaucoma, no cornea, no retina.
That's so true.
Thank you.
Wonderful case, sir. Wonderful.
Yeah, wonderful.
excellent and very well managed.
Yeah.
Thank you, Dr. Arul sir. Next up, we have Dr. Preeti ma'am. As we all know, she is organizing this OTCI webinar. I would like to introduce her. She's the medical director and head of oculoplasty at DRR Eye Care and Oculoplasty Hospital, Chennai. She's also a global examiner for FRCS Glasgow. She's the Asia Pacific faculty of AOSCMF, and her special interests are facial aesthetics, orbital trauma, virtual planning, and navigation guided surgery. Ma'am, over to you.
Thank you for that wonderful introduction. I will be presenting a case with some take-home messages in orbital reconstruction. We had this wonderful 52-year-old lady who presented to us with this kind of scenario with a total ptosis, and she also had enophthalmos, exotropia, she had diplopia and telecanthus. Now, she had all these three surgeries in the past. She had a naso-orbital ethmoid fracture with titanium plating done elsewhere, and then she had a telecanthus repair with transnasal wire. Then the plate was removed by another surgeon and endoscopic DCR was done. And then that DCR failed and she had a revision external DCR. So when we saw her, she had this kind of a malunited naso-orbitoethmoid fracture. You can see that fragment malunited there. And you can also see that the transnasal wire is very anterior. You don't want it to be that anterior. Usually we plan to put it at the posterior lacrimal crest. And the medial rectus insertion was not very clear, and also inferior rectus was not clearly seen. And these were all the reports that she came with, and they had reported that there was no ocular movements and the muscles were not visualized clearly on MRI. And she had also optic nerve thinning, but she had 612 vision when she presented to us. So you can see that her adduction was limited, depression was limited. She has very poor bells. She had about 10 millimeter of levator action and her Rho+ was positive. So she needed that correction also. So we formed a team of the Fasciomax surgeon, myself, as well as the ENT surgeon, and we had Dr. Shruti to help us with the exotropia and the hypertropia, so that is the squint correction. So we removed that malunited fragment of bone which was lying near the lacrimal sac. And then we did the telecanthus repair using an L plate so that we can use the posterior most hole to do a proper transnasal wiring. Though she had no stable bone in the medial wall. The entire medial wall was lost for her. And then we did a revision DCR along with intubation and mitomycin. And Dr. Shruti did the lateral rectus recession and medial rectus resection and inferior rectus plication. And the ENT surgeon did the endoscopic seniculisis. And then I did a medial canthoplasty for her. So this was the whole procedure by a team of experts. You can see post-operatively the transnasal wire is in correct position and the previous wire was too much anterior. That should not be done in these kind of patients. Now this is the video of how we do it. This is in another patient, but the same technique we have used. So we use a 3-0 proline suture, pass it through the medial canthus, and then pass this suture through a 26 gauge stainless steel wire like this. So that is the wire and I'm passing the suture through it. We take a knot so that it is secured to the 26 gauge wire. After that, we twist the wire along, we pass the wire through the last hole of the L plate. Here we are using the Y plate, but in the case that I am presenting, we have used the L plate so that the canthus is fixed posteriorly, but you have some, those two arms, we can fix it on the anterior bone, which is available. Usually the nasal bone is available and there is no medial wall available. So once you have the plate fixed, then we fix the plate to the available bone there. So you can see that now the Y plate will be fixed to the anterior bone, but the wire, the medial canthus is fixed to the posterior lacrimal crest. So this technique is very useful so that you get the canthus in the right place. And this was the mistake done by the previous surgeon, that the wire was too anterior. Once the screw is tight, then we drape the soft tissue over it so that the soft tissue also nicely drapes over the reconstruction. In the second stage, we corrected her ptosis and then we did the tube removal and nasal endoscopy. She needed several sittings of endoscopy for seniculitis. And, about 3 months after the surgery, she sent me these pictures. She's a PhD working in the university and she had no diplopia. She went back to her work. Although you don't have perfect correction, but she's diplopia free. Her ptosis is corrected well. Her Rho+ is negative. Now she does not have any discharge. Although some amount of watering you can expect because her lacrimal pump is already failed because of multiple surgeries and she also has eyelid scar. And these are the number of photos that she keeps sending to me because she's elated now and so happy. So these kind of reconstructions are not only anatomical reconstruction but also psychological and social rehabilitation for these patients. The take-home messages here is that earlier surgeries was done by only single specialty like a Fasciomax or a plastic surgeon. Here we formed a team of 4 of us, which and that really helped us. The bony and soft tissue reconstruction we did together. The telecanthus repair, it's very important to go to the posterior lacrimal crest. And in DCR, when we do post-trauma, we should use mitomycin and silicone intubation. Thank you very much for this wonderful opportunity.
Thank you, ma'am. That was a wonderfully managed case by her whole team. I would like to
Great.
ask, I would like to ask
Great. great outcome. And again, we are seeing what Rishi told, gave us that they become your follower and
Yeah,
your brand ambassadors too.
that's so true.
I would like to invite Dr. Usha ma'am for her comments, please.
Yeah, great job, Preeti. I think you had all that you didn't have to have. Case was fully complicated and so complex, but yet the point that you emphasize is very, very true. Often we shy away from grouping up and forming a multidisciplinary team to address this point. So often it's very good to have the facial-maxillary surgeon with you and also have an ENT surgeon. And it's just the flattening of our ego and letting the team play the role. Each one could contribute to a lot of things. And one thing we need to, as oculoplasty, is like what you mentioned, fixing the MCT to the posteriorly and then a little superior to the anatomical area that you would normally try to fix it to. That was a brilliant thing that they could have done the first time, but then of course it wasn't an oculoplastic surgeon doing the initial stage. And second thing that really that we need to emphasize is whenever there is an injury like this, an NOE often ends up with just even an edema of the the NLD could sometimes produce watering and things like that. So it's usually much later that they end up having complications with the sac. So yeah, that was also very well managed. And as you said, the pump has its own role to play, and which has failed over the multiple surgeries. But otherwise, it was very well done. Of course, the functionality has been restored and quite aesthetic as well, except there's a minimal residual ptosis, which I think the patient is happy to.
Yeah, she had a poor
I
bells.
think
That's why we planned the little undercorrection because her bells was very
that's
poor.
fine because the functionality is maintained.
Yeah,
So I think that was a brilliant outcome. Thank you.
Thank you,
That was a
ma'am.
good job done.
Another thing is her recti muscles were not located on the MRI. So that is why combination of oculoplastic surgeon with the squint specialist is very useful in this case.
Absolutely. Shruti
Because
had
Shruti was there
a
to
good
help
job
me
done.
with the squint and she could calculate also the deviation and she did a brilliant job.
Yeah, the one thing that I'd like to tell for the squint surgeons, often the muscles actually just slip, even for the those who are doing buckles, especially I see a lot of retina surgeons here, where if at all, at this point of time, people are still doing buckles, they lose the muscle. And when you want to track it, it's often found along the bone. So probably that's another point to be noted. Yeah.
Yeah, that's so true, ma'am. Everybody goes along the globe, but you will find
you
it
should
near
go
the
along
bones.
the
That's a great point. Thank you, ma'am.
Pretty. In such cases, oculoplastic surgeon can help a lot.
Oh, yeah.
Because we are most of the time tuned with all those things. So if that squint surgeon, they are doing very smooth surgery, of course. But in comparison, we are little rude, but we know all where we can find it out. That's a big opportunity for us, oculoplastic surgeon. Yes.
Thank you.
Yeah.
After that scintillating presentation, we have Dr. Shruti, who would be telling us the other side of the story as well and her own presentation. She is head of strabismology, pediatric ophthalmology and neuro-ophthalmology at MNI Hospital, Chennai. She's a joint editor for TNOA, reviewer for TNOA, IJO, BMJ and Open Ophthalmology. She has a travel grant recipient as well. Holds a patent for developing a novel wearable device for measuring dynamic sunlight exposure in children. Over to you, Dr. Shruti.
Thank you so much. I'm just going to share the screen. So This is another such case that we co-managed. So I'll be sharing another interesting case, but this will be from the other side and the other perspective. So this is from fracture to fusion, and this is about diplopia and how we managed that aspect of this case with Dr. Preeti. So this was a patient who was a 25-year-old, and he had a high impact road traffic accident, after which he developed a right-sided trauma. He had fractures of the zygoma maxilla and the orbital floor, and you can see this large defect that you can of the orbital floor and the medial wall. And this was his imaging, and you can clearly see the medial rectus that's herniated into the sinus. And not just that, you can see this large bony defect that had developed and that had to be managed. Now, at this point, he did not have any diplopia, and he was in fact free of diplopia. And a primary implant was placed to correct the inferior defect. You can see that it's not really covering too well, but you can see it's a little crowded orbit right now. There is a little bit of lower lid retraction. And of course, there was a gross enophthalmos that can be noted. However, at this point, he did not complain of diplopia. Now, because of this enophthalmos and lid retraction, a secondary procedure was performed for him, which was a reconstruction with a preformed titanium mesh. A PSI was placed, and it was fixed to reconstruct the orbital floor and wall. But this was the picture that was shown immediately on table, immediately after the beautiful titanium implant was placed. And you could see this large hypertropia that developed on table. And at this point, post this procedure, the secondary procedure, which had the customized implant, he developed vertical diplopia with a right eye upward deviation. Now, at this point, we wanted to wait for some time to allow to see how the eye reacted. So though we did have a look immediately after I did take a look, we waited for a month to see how the picture kind of stabilized, and this is how it turned out. You can still see that there is this large a large hypertropia, and now a coexisting exotropia as well. So you can see that this 20 prisms of exotropia and a 30 prism of hypertropia, gross limitation of the inferior, of depression and adduction, and a little bit of limitation of elevation. So though you can see this beautiful implant here and nicely covering the defect that was there in the orbital floor, you can actually look at the medial rectus, parts of it as well. So we were wondering what went wrong, and you can see again here. So we were wondering what to do at this point, and we wanted to immediately go in and see, because at this point we were thinking of two things. One is a flap tear, and during the placement of the implant itself, there could be a possible tear of the muscle, which could have caused a weakness of the inferior rectus, or there could have been a posterior tethering of the muscle, which could have caused a bunching up as you place the implant, and that could have caused a kind of a pseudo insertion here, creating a functional aspect posteriorly and a non-functional aspect anterior to it. So these were the two things we wanted to kind of look at, and on table we went ahead and exposed it in two ways. We did a subciliary incision to also look at how the implant was doing, and we saw it was really beautifully placed. We also went ahead and explored the inferior rectus to see whether there was any flap tear or anything. We kind of started out from the limbal incision and went all the way to the subciliary and kind of traced the muscle all the way back, and we couldn't find any flap tear of any sort. Muscle was in fact looking quite fine and free. And so at this point, we had to do some procedure to correct it. So we did a superior rectus recession on an adjustable suture. We did an inferior oblique anteriorization because we wanted a little more of depressive force. We brought the inferior oblique next to the inferior rectus. And also to correct the exotropia, we did a small lateral rectus recession. Sorry. Now, after this point, you can see that he was quite well corrected. You can see that he was at this point quite diplopia free in primary gaze. However, it's very tough to correct diplopia in all gazes at the same time. We could only give him functional vision for a diplopia free field in the primary gaze and maybe about to the lateral gazes. He was left with a very small residual hypertropia and an exotropia. His depression continued to remain impacted, but his elevation at this point was also slightly affected. And that's probably because of the large superior rectus recession and also because of the inferior obliques anti-elevation effect that takes over after a period of time. So this was how we looked, and he was very happy. In fact, he started driving again, and most of his daily activities are quite okay. So the pearl here is that it's very commonly easy to associate mechanical restriction with inferior, orbital wall fractures, and surgeons typically fear muscle tethering and all of that. Whereas here, when we look at the whole concept of it, this was immediately after placing the implant. You can see this large hypertropia with an intact inferior rectus on exploration. And all of this looks and points towards something of an unmasking of a pre-existing inferior rectus paresis. So probably the inferior rectus paresis could have been developed at the time of injury or maybe during the first procedure. And after the floor repair, which has actually released the inferior rectus, brings about the unmasking of the paresis itself. Now, this is not a single case. We've had a few other cases that with a similar presentation. This was another patient who you can see this hypertropia again. Good looking inferior rectus, and then we kind of had to correct the diplopia. Another, again, an army officer who had underwent trauma, and then again you can see the hypertropia getting corrected. Very similar looking pictures that we are seeing. So what we learned from this is that orbital floor fracture repair, a good one especially, can unmask a pre-existing inferior rectus paresis, and it's important to counsel about the possibility of diplopia before you go in for these fracture repairs to ensure that the patient doesn't really get shocked later, and also the possibility of future surgeries. It's also important to document these. So it's a request to the oculoplasty colleagues to document a 9-gaze photograph before going in for fracture repairs to make sure that we know what we're getting into. And again, superior rectus recessions plus or minus inferior oblique anteriorization procedures can really help in alleviating the diplopia, at least in the primary gaze. And this was the patient after 1.5 years doing well. So thank you so much for your kind attention.
Yeah, that was wonderful. I think I learned from Shruti that I should take all the 9 cardinal positions because I used to take only from the oculoplasty point of view. And important thing here is orbital adherence also. When the patient has severe trauma and multiple surgeries in the past, they tend to fibrose a lot and they have orbital adherence also. And like she said, initially the muscle is entrapped and there is so much adhesions. We don't know if it is paresis or paralysis. Only after release it gets unmasked. So this was a learning point for us. Dr. Nina, would you like to highlight some points on this?
Yeah, exactly. So there are a few points in the pre-op itself which gives you a clue that this is the first case, it's a combined paralysis. See, the marked hypoglobus is actually making the eye look hypo. But if you do a cover test, you may find that he would have very minimal hypo, or it would be rather a hyper in primary gaze and down gaze, which tells you that the inferior rectus is not working well. So that would be one point. And if you ask him to do an inferior saccades, those saccades would not be very good. If you have a purely restrictive strabismus, your saccades to down should be still good. But having said that, it's tough to detect in the first go. So it's always a good idea to take the 9-gaze and to counsel the patient for a subsequent strabismus intervention. If you think that, it's not. So typically when you have an inferior floor fracture with entrapment, you get a hypo, isn't it? A hypotropia with restricted elevation, which is due to the tight inferior rectus preventing the elevation. So when you release the inferior rectus from the fracture, everything is usually okay because the eye goes up and you don't have a problem. But when you have a combined palsy, the restrictive element is already there. The inferior rectus is entrapped. And if it's undergone a posterior, entrapment, the neurovascular bundle also can get entrapped. If it's been there for a while, or there is another, combined paralytic element, the paralytic element is unmasked by is masked by the restriction. So
correct.
when you correct the restrictive element goes away and the eye suddenly goes up. And that's when the previously, not too bad cosmesis becomes really bad there. The eye goes hyper and patient has diplopia. So it's always a good idea to tell the patient that you will require, you may require a strabismus surgery, and it's good idea to take the 9-gaze pictures. Another thing, if you have a hypertropia pre-op, before you do the intervention for the fracture, is to think about a coexisting superior oblique palsy. Because sometimes the superior oblique palsy could be due to a head trauma. The most common cause of a superior oblique palsy is a head trauma. You could have it could be an RTA, it may not be related to the fracture directly. It could be a coexistent superior oblique palsy. That will also unmask once you release the restriction, that will also unmask. Another thing I want to say is that not only are we going to, our aim is to make the patient diplopia free in the primary gaze and down gaze. You can, forget about the up gaze, but without the down gaze, the patient is going to be very uncomfortable. If he wants to read or walk or do anything, his down gaze has to be free. So the second case in which you did plication was very good because yes, we have done plication for small residual squints in which the eye was not going down very well. That helps very well. So you have to take the case each one by one and then, decide what it is. But it's a very good idea to do the FDT on table. Once you release the restriction or even before you take up of the squint surgery, it's a good idea to do the FDT and FGT. So if you do the FGT, you may find that the FGT for inferior rectus would not have been very good. That also tells you that, okay, the restriction is relieved now, but the FGT is not good. So that shows that the muscle is not functioning very well. But all in all, I would have done a little different in the first case is probably I would have done a inverse snap, or that is, I would have transposed the horizontal, lateral and medial rectus to the inferior rectus, because the inferior oblique recession is also, anteriorization is also a kind of transposition. You have put it very close to the inferior rectus. It gives you a little more depressing force, but an inverse snap would have given you more depression and would have helped to correct the down gaze, the deviation also better, but otherwise very well managed.
Excellent points. I think the point about ischemic component also being there, like you said, there can be a vascular injury also. That was excellent. Thank you so much.
Thank you.
Thank you.
And I would like to add here, sometime it happens that you are not able to do FGT on table. Most of the patients are under GA. And even pre-GA, if you start, there are always chances of oculocardiac reflex. So it's very well said by Dr. Neena that we should do FGT, but then we have to take these 2 points also into account.
Yeah.
Thank you. Now we go to the last speaker of today's session, Dr. Bhaskar Srinivasan. So he's presently the medical director of Code Eye Care Chennai. He did his MBBS at Topiwala National Medical College, MS from AFMC Pune. He was a university topper in MS, and he has fellowship in cornea and anterior segment from Shankar Nethralaya. Has 100 publications in his name, and his area of interest are ocular surface disorders, lamellar corneal transplantation, pediatric corneal disease, and refractive surgeries. So, you're next.
Very good evening, and I would like to thank Preeti and OTSI for the opportunity. Just a second. Yeah, the slides are visible?
Yes, sir.
Yeah, so I'll just be briefly going through acute ocular burns and then ending up with a case which basically tells us how we should be looking at managing an acute burn. So some of these pictures are from my time at Shankar Nethralaya. So when you look at chemical injuries, the most commonest question that is asked is, will medical management suffice? Will surgery be required? Whether one amniotic is sufficient? What to do if the amniotic disintegrates? But to answer all this question, what we need to know is the effect of the chemical burn, and we need to grade the severity of the injury that we are dealing with. With respect to severity of the injury, yes, from Rupert Hall, we've now shifted to Dua's classification, which is one step forward because it looks at the conjunctival involvement, it looks at the limbal involvement and kind of prognosticates it. But even with Dua's classification, when you're looking at conjunctival and limbal involvement, it might not always prognosticate. So 2 images of 2 different patients, both graded as grade 6 in Dua's, ended up with different outcomes, one requiring a keratoprosthesis and one requiring an autoslet. Tells you that the prognosis varies on a case-to-case basis, and it depends, in addition to the conjunctival defect and the limbal involvement, it defects on other factors also. With this in mind, we actually have published this, where we spoke about the I's and E's of chemical burn, where we're looking at you need to deal with the inflammation, you need to deal with the ischemia, you need to deal with the exposure, you need to deal with the epithelial defect, and you need to look at the intraocular pressures. So these are the 5 parameters that you would always want to assess when you are assessing any chemical injury. So, and with that, we also published something called as EPICS, which is there in the Indian Journal of Ophthalmology, where we kind of gave a grade as to how you would want to assess and analyze each of these parameters and decide on managing them. So if you look at an epithelial defect, yes, if it's small, a bandage contact lens might work. But if it is a very large defect on the ocular surface and there is no cells or the cells are way away from the cornea to epithelialize it, you might want to add some sources of cells, which is what is the rationale for the allogenic limbal cells that we proposed. And we have published the initial results, and we also compared it with the previous version where we were only doing plain amniotic, and said that the outcomes are much better if you use alloslet in grade 4 or worse Dua's classification of chemical injury as such. So this is just a picture from our publication where a grade 6 burn with a scleral melt with a lime plaque underwent lime plaque removal, lamellar graft, alloslet, and subsequently at 6 months underwent an autoslet, maintaining 6/9 vision in that eye over a 10-year period. Again, even when you're looking at defect, that is one parameter. When you look at the sclera and you see an absolute white sclera in a chemical injury, it means a very grave prognosis because all the episcleral vessels have gone. They've got destroyed. So this is what is called as scleral ischemia. And if you have an absolute scleral ischemia, you need to get vasculature there. Otherwise, you will not have the epithelium growing on the surface. This was proposed way back in 1997 by Ryan, but unfortunately, it was not so commonly utilized. So this is an important aspect which decides how your eye is going to do. And for that, you will have to do something called as a tenonplasty, where you will mobilize the vascular tenons from the deeper part of the fornix. You'll basically cut all the necrotic tissue, mobilize a healthy vascular bed, and suture it close to the limbus. And in this case, because the defect was severe, we combined it with an alloslet where we placed an amniotic membrane on the surface, stuck it with glue, used a conformer to kind of drape the amniotic onto the tarsal surface, also sutured the tarsal surface, then stuck the bits on the ocular surface, and then removed the conformer, put a bandage contact lens, and did a tarsorrhaphy. So when you're looking at chemical injuries, you need to know the conjunctival defects, you need to know the ocular surface defect in terms of the limbal involvement, the scleral ischemia, the digital tension, and exposure. And we've kind of called this as a SCORE score. It's freely available for people to use at our website, where it will give you a dated timed assessment of the severity. This is not talking about the management, or at least you look at these parameters so you know when you have to intervene in these cases, and when the parameters get worse, you need to intervene. So the limbal involvement, we have graded it like Duas. The conjunctival involvement, we have graded it as 1 to 4 based on 25% loss. The scleral ischemia is also 1 to 100 based on 25% loss. IOP is either normal, low, or raised. Exposure is mild, moderate, or severe. And this is what we've called as a code score. And the idea is whatever score you start off with, you need to analyze that. And the idea is at the end point of your healing, it has to all reach code 0. Because unless you reach an epithelialized surface, a normal pressure, a non-exposure state, you are bound to have problems in further healing or recovery of those patients. So with that, we come to the case. This was a bilateral burn with severe grade 6 Dua's classification, severe scleral ischemia, severe conjunctival ulceration, severe limbal defect, has a bit of cataract, and gross hypotony. So what did we do for her? So for the large conjunctival defect, we did an amniotic. Along with that, because the limbus was completely lost, we did an allogenic slet. There was complete scleral ischemia, so we did a tenonplasty. There was exposure, we did a skin graft. Pressure was very low. We started the patient on systemic steroids. 2 weeks, the pressure was not building up. The eyeball size was becoming smaller. One eye had already become 14 mm. The other eye was 15 mm. We were not sure what we could do next. We decided to go in and prevent the eye from going into phthisis. So the option was go in, do a lens aspiration, do a vitrectomy, put in oil. At least you have the globe to fight again some other day. We did one eye. The axial length, which was 15, the axial length of 14, we operated about a week later, but by the time the eye had already started, the retina had already got damaged. This eye subsequently underwent a Boston type 2 keratoprosthesis with a retop-up of silicone oil. 2 weeks post-op, patient had an endogenous end-off, developed a melt. We retook the patient up, did a revision keratoprosthesis, and maintained. At 5 years post-op, she's maintaining 636 in her only eye. So the idea is, if you manage the acute stage well, you live to fight another day. You miss your timelines, you will lose the eye. So we have the thing on the website. You can actually go and check, because it's you can enter the demographics, the time, because it's also important as to what time the patient has presented to you. A grade 6 at day 1 versus a grade 6 at 1 month indicates a totally different prognosis, because it's been probably much worse to begin with. Thank you.
Superb case, Bhaskar. Dr. Fogla is here to discuss the case.
Yeah. I think excellent. So basically, it is very vital that sometimes when you have these kind of injuries, the visible damage on the face is so much that often the eyes, or you tend to ignore. You think about the plastic surgeon takes over, the dermatology people take over, and by the time the case is referred to an ophthalmologist, the eye is already beyond being able to salvage. So that basically shows that whenever there is whether it's a road traffic accident or a chemical or a thermal injury, referral to the ophthalmologist should be given, no matter how bad the initial outlook may be, because as he rightly pointed out, that if you can prevent further damage, later on it becomes possible to salvage vision, although it requires highly specialized procedure. So these are not something that can be done at all places, but at least tenonplasty or covering the surface with the amniotic membrane, these should be done so that at least the eyes has the potential to undergo subsequent procedures.
I mean, if I could just add one point, sometimes we get a lot of referrals where they say that the eye is very quiet after chemical injury. If the eye is quiet after chemical injury, it's actually a bad omen. So if it looks white and the patient has had a chemical injury, your the threat perception about it of the damages has to be much higher. So you don't just go only by the look of a whiteness in the eye. Again, it's difficult to estimate scleral ischemia in the initial phase because you'll also have chemosis which will kind of mask it. So you just need to keep a tab of following those patients up. As the edema settles, the extent of scleral ischemia kind of manifests. So that's why we said you need to document the extent in a way that you will not forget to look at all these parameters when you're looking at a chemical injury.
Yeah, I had a patient who had he was working in a factory and he had acid injury on his face. And a referral was given by the plastic surgeon who were trying to reconstruct his face. And when they opened up the overlying skin, they said, "Oh, we are seeing something inside. Can you come and take a look?" Actually, there was no cornea. It was basically the iris and everything. So I took cornea scleral graft. I placed it over basically to save that eye, place sutures, close it, and then they close the skin. Finally, that patient I referred to Bhaskar and Geeta, and they did a OKP in that eye, and that patient got back vision. The patient is from Africa. And so I'm saying that sometimes cases which look very hopeless after a chemical injury still may have the potential, because what is visible on the surface is what is behind, So sometimes we should not give up on such cases.
Oh, I think that is a wonderful last tip, that never give up in trauma. It can take you to any direction. I think we are running out of time now. We have crossed our time limit. We've had a wonderful array of cases and lots of tips to learn from. Dr. Preetham has actually jotted down some key points for all of us to remember. So we'll just summarize with that. Like, he has 2 points for each case that we can all revise. Thank you.
So we had an
Thank you,
excellent
Preeti.
array of speeches today. Starting with Dr. Rishi, where we had just a small talk on one central suture at the visual axis, creating a visual impact, and then coming back, redoing the suture, and doing a topo-guided PRK to salvage vision, which tells us that you never give up. That was the message throughout the trauma session today. And he also documented that ASOCT was invaluable for documentation and further planning. Then we moved on to Dr. Murli, who showed us an important case where you try and avoid doing a mixed surgery in angle recession glaucoma, which would actually compromise the angle further, and to exercise a meticulous mitomycin C handling during a trap surgery for such cases where low endothelial counts were also documented, so as not to cause further damage, and showed excellent outcomes postoperatively. Moving on from anterior segment, then we had two excellent talks, one by Dr. Nivian, who showed a completely innovative approach by doing a simultaneous cataract surgery and an intraocular foreign body removal in the same setting. For which I think Dr. Rajan commented saying that manual posterior capsular access can be preferred over vitrector assisted, because sometimes the control is much better when you do it with the manual approach. High magnification is crucial while operating these cases. So that was the choice why in focus lenses were used. In Dr. Sachin's case, it was interesting to have a contact lens in the vitreous cavity. And it was even more innovative to stain it and remove it piece by piece. And we also learned the importance of B-scan to localize IOL, which has gone behind the retina. We moved on to Dr. Aral Mosi's case, where it went on for years, where multiple ripples were caused with the initial trauma, and then all the barriers of anterior segment, posterior segment were breached there, where you needed an approach where everyone had to contribute at one point of time individually. We had an excellent multidisciplinary approach of two presentations, one by Dr. Preeti and one by Dr. Shruti, where together they showed why multidisciplinary approach outscores an independent approach. Simultaneous bony and soft tissue reconstruction restores both function and aesthetics, while orbital floor repair may unmask inferior rectus paresis. It's important to keep in mind that it can be both restrictive as well as paralytic. So always try and do, if possible, an FDT and FGT in these cases. To end this presentation, one of the most complex cases I have ever seen presented by Dr. Bhaskar today, where they got out an unique code classification, including both exposure as well as scleral ischemia, which were not previously documented in Dua's classification. That is something I learned personally. And more importantly, to keep aside all the logics and science, never give up, and you'll live to fight another day. That's the message in acute chemical burns. It's very inspiring, the work you do. That's all I have for today. Thank you, everybody, for joining in, and thank you, Dr. Preeti, for the opportunity for such an excellent session today.
Thank you. Thank you, everybody, for joining. In spite of all the difficulties, many of you were traveling. They have taken the webinar from the car, and I really thank you all. Dr. Basin, would you like to end the webinar?
No, I just want to thank everyone for the contribution towards the science and the ocular trauma in each and every subspecialty. And I really look forward. And Preeti, you have compiled this whole webinar in a beautiful way, I would like to say again. And your selection of the commenters and the panelists was excellent. And I appreciate everyone. Bhaskar, your case was very, very good. And the comments by Rajesh was equally good. And never give up. That is what is the ultimate message of this webinar. Thank you all. Have a good time. See you again. Good night.
Night.
Thank
Good
you.
night.
Thank you.
Bye.
Bye.
Bye. Thank you.
Bye, boy. Bye.